everyone to Solving Kids Cancer UK's Neuroblastoma Parent Symposium 2026 and the first of our six-part webinar series. Today's entitled Finding Trusted Information, Navigating the Neuroblastoma Journey. My name is Donna Ludwinski from Solving Kids Cancer, and it's my pleasure to be moderating and presenting in this session alongside Mandy Berriman and Dr. Ramya, consultant pediatric oncologist at University Hospital Southampton. Before I begin, I'd like to draw your attention to the Q&A function at the bottom of the screen, where you can submit questions at any point during the session. There's also the option to submit questions anonymously if you'd like, and to upvote questions you'd like to see answered. We'll come to questions after all the presentations have concluded. So I'd like to start my presentation. And let me pull those slides up. Here we go. And start. So thank you so much for joining us for this presentation. So this session is going to focus on why we as parents need clear, trusted information, the sources that we rely on, and where gaps and pitfalls exist. The takeaways are really depending on evidence-based, peer-reviewed sources and using caution with social media and AI. So my son Eric was diagnosed in 1991 when he was 6 years old with high-risk neuroblastoma. He relapsed at age 20 in 2005 and went through multiple therapies and died almost 16 years ago. So the core of this talk is about how do we get knowledge. And interestingly, this quote from the 1700s on the side of the British Library is every bit as pertinent today as it was then. Knowledge is of two kinds. We either know a subject ourselves or we know where we can find information on it. So what do we really need to know? We need to know about the disease. We need to know about the treatment. And it helps to discern research information if we understand the process and statistics that go behind that. So it's very difficult to disentangle information from decision making because the whole purpose of the information is to help us make informed decisions. So it's also, a good perspective to understand just how rare neuroblastoma is. There are over 200 types of cancer. Pediatric cancers account for 1% of all cancers, and neuroblastoma accounts for 5 to 7% of all pediatric cancers. So that is 0.07%. We also know it's a heterogeneous disease. So there are many subtypes of neuroblastoma that behave very differently. And you've probably all seen this before, but the little pink triangle in this represents neuroblastoma out of all pediatric cancers. So you can see it's a very a small piece of the pie. So decision-making models have evolved over the years, and it used to be that if the doctor contained all the information, they could make all the decisions. There was really no other choice. As time went on, the emphasis on patient education in order to make more informed decisions evolved. And so now the emphasis on a partnership where patient and parents are well informed and partner with clinicians to make the best possible decisions. Of course, this is complicated when it's not just the patient and the doctor involved. It's really the parents, the doctor, the child, and then the community that surrounds the family. So that's family and friends, web sources, and patient communities. And then we need different information at different time points for different reasons. So obviously through the continuum, there are different needs for reliable information. If you were to map out how complicated neuroblastoma decision making could be, you'd come up with something like this, where you start at the beginning at diagnosis, and every green line, everything's going just fine. Every red line, something is not going well and represents another decision point. It's also important to realize that the perspective between the parent and the physician and the goals in the decision making can vary, especially when dealing with relapse and refractory neuroblastoma. Often, first and foremost is a desire for cure for parents. And parents also want really comprehensive information. They're concerned about logistics and quality of life, whereas physicians sometimes move quality of life a little higher on the list, but they are also concerned about ethical issues, local options, and then perhaps focusing on their own research. And looking at over time, it wasn't long ago, most parents were told, don't Google neuroblastoma. Now things have gotten even a little bit more interesting because now we have artificial intelligence, we also have social media, we have so many different sources that vary greatly. There is a price to pay for knowledge because sometimes that can really represent a huge burden of responsibility for parents. However, the consensus, throughout the medical community is that health literacy is needed so that with mutual trust and respect in the doctor-parent relationship, informed parents are best equipped for the difficult task of making choices for their child. So this is a blast from the past. If you had a child diagnosed in 1991, this is how you found information. You went to a university library and they had abstract books that you looked up keywords in. And if the journal was that you chose to look at wasn't a new one, you had to go get the microfiche out, which were microscopic little pictures of each page, and then you would print it out at the exorbitant rate of 5 to 10 cents per page. So it was very difficult to gain information. Now we have the opposite situation. There's so much information to be had, it's absolutely mind-boggling. So I want to talk about a few of these. We could spend all day to really do a deep dive in different sources of information, but I do want to highlight a couple in this presentation and then a few I want to touch on here, and that includes the FDA and the EMA. They are really actually excellent sources of information for approved drugs because all of the preclinical and clinical experience that and evidence that went into them becoming approved drugs is in the public domain. You can also see deliberations like the oncologic drug advisory committees. Those are also in the public domain. Lots of interesting information to be had. So if you're really trying to understand side effects and other issues about approved drugs, I'd go there. The other one that I will just touch on very briefly is meeting abstracts are also useful informations of really recent information because they're not published yet. So if ASCO is a big meeting that happens every year in June. About 30,000 oncologists attend that meeting, and there's a good representation of pediatric oncology there. If you go into ASCO, you can search abstracts for neuroblastoma, and you'll find hundreds and hundreds of abstracts. And then the rest of these I want to touch on a little bit more deeply. So our real issue is trying to discern, what's good information versus not so good. And we need help in interpreting that. So PubMed was launched in 1997. There are 39 million citations now in PubMed. The first neuroblastoma paper was published in 1910, and it was basically a case series of 5 children. That's when it was first named neuroblastoma. You can see it's heavily weighted toward recent times. We're from 1990 to 2026, 43,000 papers have been published, and it roughly works out to be about 2,000 a year. So if you go into PubMed, I put a little circle under the user guide under the search bar because that's actually very handy if you want to learn how to do more sophisticated searches. I mean, searching for a single keyword isn't too difficult, but sometimes you want to find other things, and there was a lot of useful guidance there. If you go into PubMed, you'll see there are over 50,000 papers on neuroblastoma. And you can create an alert so that you are notified when new papers come out. If you reduce that using the filter for clinical trial or clinical study, you could see almost 900 clinical studies are in PubMed. So that's a lot of information. How do I know which is what's good, what's not? Some is very solid, some might be debated, some might be unknown. Strong opinions might still be held within the research community about the quality of some of the research. So when you're looking at these, look at the author, the institution, look at the journal. Is it a high impact journal? The numbers, if you see a paper on 6 children with neuroblastoma, that's not going to be much to interpret. And then looking at the characteristics of the children themselves, if you see a paper that includes low, intermediate, and high risk, it's also going to be difficult to know if it really applies to you or your child. So moving on to clinical trials. The National Library of Medicine started the NIH listing, or clinicaltrials.gov, in the year 2000. So it's been around almost 26 years. Right now, if you search for neuroblastoma, you'll see that there are 753 trials will come up. Now, that's all trials in the record. So if you limit that down to what is recruiting and not yet recruiting, you'll see it reduces it down to 130 trials. That's still a lot of trials. You can also set up an alert for these when new trials come out. If you look at the map feature, you can see that it's heavily skewed toward North America. It's 72 trials in North America, whereas in Europe it says 27, Asia 31. If you zoom in the map to Europe, you can see that it's pretty sparsely located around Europe, and with some lack of access across borders, this really shows, quite a discrepancy in terms of clinical trials. So what about social media? Obviously, this is something that we can't stuff back in Pandora's box. One interesting thing is this is a new phenomena of actually learning about early responses in early phase trials. Before there was social media or any means to find out an individual's experience in a trial, it was virtually impossible to find out this information. And that goes for toxicities as well. Interestingly, when dinutuximab beta was being tested in Europe in the early days, parents were posting about strange side effects of one pupil being dilated more than the other. And this was before the research community actually knew that that was a side effect of anti-GD2 antibody. We have to always keep in mind that what we see on social media is anecdotal. Is it even accurate? Is it a similar case to your child? And watch out for the peer pressure that can come from social media. And then, the last line is always use caution. And then similarly for AI, I can tell you that even though there was a paper that came out recently that said over 200 million people are using AI for health information now on a regular basis, this is not going away either. But I can caution you, you can test different models to see what clinical trials might come up. And it's very poor at kind of selecting out clinical trials that might be appropriate. AI is pretty good at explaining terms that are unfamiliar. And certainly you don't want to upload your child's health records to an AI model. There are a couple new ones that have just come out that the idea is to secure that information. But in short, stay tuned for a future webinar on this topic. It's an absolutely huge topic, and a lot more could be said. So another general search that you can do is set up an alert, a Google alert for neuroblastoma. I've had one for, I think, about 20 years. A lot of really junky stuff shows up here because even AI-generated news articles from, say, a preclinical publication comes out sounding like, neuroblastoma has been cured. There's a new drug and it's cured. If you look further into it, it might not be very good preclinical work, and it might be 10 years from the clinic. So there's just a lot of stuff that comes up in here that's not great. Of course, some of it is very good. A question that comes up an awful lot within the family community is, what about herbs, botanicals, supplements? This is the only site I've found that's really evidence-based. Sloan Kettering has this. If you search Sloan Kettering and herbs and botanicals, it comes right up. If you look in there are 300 herbs listed in their database, and they're very well researched. In other words, it'll clearly state this will not work for cancer, this is toxic, or there is some evidence that this could be helpful. For example, if you did a search on omega-3, which is a supplement, it's the article itself has almost 100 references to the scientific literature, so it's very robust. So the other thing I wanted to be sure you know about, we'll hear a little bit more about later from Mandy, is the REDMAP resource. It was developed by Dr. Helen Pearson. It's an excellent resource for relapse and refractory sources of information and decision making. And then my last takeaway comments for you is, of course, depending on your child's oncologist, is extremely important. It's a partnership. It's not a one-way burden for you to bear. Learning to use the tools that are available are very helpful in terms of increasing that health literacy. And then again, caution with social media and AI. And with that, I will move to stop sharing and introduce Mandy to come on camera. Thank you, Mandy.
Right. Oh, excuse me. Sorry. I'm Mandy Berriman. My son Peter was diagnosed in 2019 with intermediate risk neuroblastoma. We had a very straightforward experience to begin with. He had chemotherapy, rapid Kojak. He had surgery, which completely removed the tumor in his chest, and he had radiotherapy. And then following that, 6 months on retinoic acid. And that was all completed in February 2020. And we didn't really have to think too much about any decisions along that way, because sort of going back to Donna's chart, we were very much on the green lines all the way through that. Then in August 2020, he relapsed, and this time it was high-risk neuroblastoma. He had a tumor on his skull. He had metastatic disease, bone marrow, pelvis. And we were suddenly faced with a situation where there was no set treatment pathway. He started off on the Beacon trial, randomized to chemotherapy only. And when he progressed on that, he was switched over to chemotherapy with immunotherapy. And this, after 6 cycles of this, he still had visible disease on the MIBG scan. So we were faced with decisions to make, sort of going forwards, where he hadn't had a complete response to the treatment, but there weren't really any other options that were available for him on the NHS. So we had to sort of think ahead about what he could do next and where we could go to find information. I mean, we were very lucky with our consultant, who was always open to discussing any options that we brought to him, and he would help us to understand them, but limited slightly by the fact that he could only offer us what was available on the NHS. So at that stage, I think we were in touch with Solving Kids Cancer by then, and we were chatting to Donna on a fairly regular basis, which was an incredibly useful resource. There's not much that Donna doesn't know about all the various trials out there. But it was difficult to know which way to turn. So we had various different ways of finding information. Solving Kids Cancer was kind of our starting point of where can you point us to? How do we get a second opinion? We sought out second opinions with people, consultants in Spain and America, trying to sort of work out where Peter could go next with his treatment. I did use Facebook groups a lot, and they come with the caution that Donna's already explained about. But I think where I found them really helpful is that they were a place to see patterns. So there are a lot of posts on Facebook groups that are both helpful and unhelpful, and you have to kind of learn to filter out which ones are good for you. But what I did find from using them was you would see people talking about the same things over and over again that were either a good thing or a bad thing. And so you think, okay, this trial sounds really interesting because a lot of people are talking about how it's worked in this scenario. A lot of people are talking about how this particular trial has had these side effects, and it just gave us a wealth of information to then take to a more reliable source where we could talk about whether this was actually something to look into. So I think that they come with a health warning simply because people go to these Facebook groups when they are in a difficult place. So you are absorbing other people's difficult situations while you're still dealing with your own difficult situation. And that can be challenging at times. So I think when you are using the groups, you have to be able to give yourself permission to step away, to not read every post, to not comment on every post, to not feel that you've got a responsibility to be part of every post. But they are a fantastic resource for finding out what is happening in a wider arena, because within the UK, we did not find a single other person who had had the same experience as us. Whereas on the Facebook groups, there were a few more, and I was able to sort of gather a bit more information that way. I did use the clinical trial websites a lot, but I found them really hard to navigate. I found that despite, I'm not an uneducated person, but I'm not a science educated person. So I sometimes found the terminology quite hard to understand. But again, they were a good starting point. So if I found out something, a trial that was open, that sounded like it was helpful, I could take that information to our consultant or to Solving Kids Cancer and just say, tell me more about this, tell me how this could or couldn't work. I found the previous Solving Kids Cancer symposiums incredibly helpful, and they are still available. A lot, the videos from those previous online symposiums are still available to watch. So Solving Kids Cancer has a video library if you want to go back and look through some of them. They were particularly helpful in giving me information about data, which I didn't understand really. I think data is one of the things that I found hardest to understand in this whole journey. And I know that some parents, that the whole data thing is something that they really get involved in, and that just was not something that I found easy to get my head around. But seeing data laid out in charts and people's presentations explaining that data really, really helped me to sort of filter out, okay, this trial looks like something I could really look into a bit further because the data looks like it could be helpful. But then again, with Peter, data hasn't always been helpful because he's a fairly, unusual case. But it was a starting point for conversations with other people where I could say, right, this data says this. Could this be helpful for Peter? And then that opens up a conversation. So a lot of the time, I was finding information in places and then taking it back to somebody that I trusted, whether it was a consultant or someone at Solving Kids Cancer, or even, going back to the Facebook groups. You kind of learned to figure out which people were posting on there whose opinion you valued, who had had enough experience in different fields where you could say, do you mind if I message you about this, and then have a sort of private messaging about it. That can be a really, really helpful thing as well. Via the symposium videos, I found out about the National Neuroblastoma Advisory Panel, which I know Dr. Ramya is going to talk more about shortly. But that was really interesting to know about that, because I had no idea that was even a thing. And it was something that I then took to our consultant and said, when we got to the point of not really knowing what the best treatment for Peter was going forwards, I was able to say to him, look, can we take his case to the neuroblastoma panel? And the point at which I took it to him, he said, it would be useful, but not yet. We need to sort of see where this particular treatment goes first. But for me, knowing from that video that I watched that I could self-refer to the neuroblastoma panel, it was almost like something I tucked into my back pocket, so that if I got to a point where perhaps we weren't quite on the same page as our consultant, I could actually say, well, actually, I will take it there. I'll self-refer and just see what I can get back from that. But in the end, he did, he did actually take Peter's case to the panel. We got some helpful information back from it. It definitely informed our decision making going forwards, and it was a really helpful thing to do. And then finally, just to say a bit more about RedMap, this is simply the resource that I wish we'd had. I got involved with the RedMap project with Helen Pearson when she was first coming around to the idea that actually some parents needed some sort of central place to go for trusted advice. And I was really happy to be on board with helping to sort of give my experience and feed into what would be really helpful to be on the website. And what has come out of that is a website that I truly wish had been there when we were making decisions. It has got so many helpful resources on it. It's not just about how to find trusted information. It's about how to find support. It's about the psychological side of things. It's about how to make decisions, because making decisions, it's such a difficult thing as a parent when you're making that decision and you don't necessarily have the data to back it up, and you don't know whether the decision you're making is right. And to add in, Donna shared that slide about the sort of different priorities that clinicians and parents have. I think actually the thing I would add to the parent side is that one of the massive things that we're doing as a parent when we're making decisions is trying to minimize our future regret, because these decisions are so huge and they have such huge ramifications. So REDMAP's got a whole section about decision making and the impact of continual decision making, which was the situation that we found ourselves in, continually having to make these decisions about, and the responsibility feeling very much like it's on us as the parent, because we were being told, well, there isn't really anything else in this particular treatment pathway, but you could consider this trial or this trial or this trial. There's not much data, there's not much, we don't know what the particular outcomes might be, but you can make a decision to do this, we will support that decision. But it was very clear that the decision was ultimately ours. So there are a lot of resources on REDMAP to kind of support you through that difficult situation. There's a lot of information on there about how to understand the terminology of clinical trials. I think if I'd had REDMAP website when I was trying to navigate the clinical trials websites, I might have had a better idea of how to understand what it was actually saying to me. So I think that's really important. And it just, excuse me, I think that there are just many areas of the website for whatever part of the treatment pathway you find yourself on, whether that is you're at the very beginning of making decisions, you've repeatedly had to make decisions, or even you're at a stage of considering palliative or end of life decisions, which again come with all kinds of responsibilities on you as a parent. There's something there for everybody, regardless of where you are in the journey, and I cannot recommend it highly enough as a resource that is trusted. Just to sort of finish with where we are now with Peter, we had about 6 months of not doing any treatment after he finished the treatment that was available for him in the UK, while we tried to make these decisions and tried to work out what the best thing was to do. He then went on a DFMO trial for 2 years, which he finished 2 years ago, almost to the day, back in January. Partway through that trial, we requested a PET scan just to try and find out where we were up to, because we were continually getting MIBG scans that were showing the disease was still in his skull. He'd been disease-free in his pelvis and in the bone marrow for quite a long time. The PET scan came back with negative disease, so it was a not active disease, I should say. So the situation that we are in now is that when Peter has his checkup MIBG scans, he still has disease showing up on the MIBG, but we know that that disease is no longer active because of the PET scan we've had. So he's now classed as no evidence of active disease. And we're hopeful for the future. We continue to be very grateful for where we are, and we are 2 years out of treatment now, still with our fingers firmly crossed, but in a much more positive place. And I am hugely grateful for all the people along the way that helped us to navigate all the different information that we had to navigate to get there. All of the links and places that I've mentioned are on a slide, which I think Georgina is now going to put on this screen so that you can see, so that you can have access to all the links that I've talked about. So these are all the places that I have been to over the years, with the exception of REDMAP. I didn't actually go there, obviously I was involved in helping it be there, but these are all the places that I would highly recommend, alongside all the ones that Donna's already recommended. And that's me finished, so I will pass it to the person.
Oh, thank you so much, Mandy, for that excellent talk. So now we welcome Dr. Ramya to talk about the Neuroblastoma National Panel.
Good afternoon, good evening, everyone. It gives me great pleasure to be here with you all today. and share with you some of our UK experience as the chair and lead for the National Neuroblastoma Advisory Panel. So I'm a pediatric oncologist in Southampton, and what I hope is help you with what I think Mandy said and makes you feel how overwhelming it is when your child is diagnosed, let alone with cancer, but with neuroblastoma, which is so complex. For some people, it is like a huge cloud that is sitting above their head that you just can't get through. And for some parents, they want to know more and more information, and you get deeper and deeper into a black hole. But how do you navigate this journey, which is life changing for you as a family, but more so for your child, but at the same time, maintain yourself through this whole thing and maintain your family? So let me clarify, first of all, what we mean by second opinion. And how does a neuroblastoma advisory panel in the UK act as a resource for you in that manner? How can this panel actually help you as a parent? But also, I understand completely this is a UK resource, but give you some pointers as to how you can actually ask for second opinion, whether you're in the UK or any other place globally. But I guess for me, it is finally the reflection on understanding what matters to most of the families. So, what do I mean by a second opinion? It could mean multiple things. When you're in this time point, like Mandy described, overwhelming, and you just can't make the right decisions about where do I go, what information is right, just asking another specialist to review your child's diagnosis or what situation is itself can constitute a second opinion. But let's not forget, childhood cancers and neuroblastoma is complex. And as a part of good care, we as professionals will always be seeking other professionals' opinion because we don't have egos about this. Ultimately, we care for your child. So automatically, this is something that already happens if you're not aware. Or it might be at those time points that we just heard, like, for example, diagnosis that is difficult, or where changes in treatment have to take place because your pathway has gone from green to red, or it might be at the time of relapse when we as professionals also seek what is it out there in the UK, which we know is going to be quite limited. But how do we help you in terms of knowing what else is available around the world that might be relevant? So, why do families seek second opinions at all? It is basically so you want to reassure yourself that the diagnosis and the treatment plan is the best for your child at that time point. Obviously, like we heard, it's very, very difficult to know what is the best and where is available options, and if there are clinical trials available for your child that you're not aware about. Sometimes, as we said, that information is so much, and put the whole thing into a chat GPT, it can literally throw off a lot of things. But how do you clarify that? Who is going to explain this to you and break it up in a language that you understand? That is, again, something you can seek from this. And as we said, it's these various time points trying to make sense out of that whole cloud there as to what is really relevant for my child and for my family. So the National Neuroblastoma Advisory Panel, I'm really proud to say, it has been a conglomeration of multiple multidisciplinary team members, and we've been running it successfully now for 9 years nearly in the UK. And very briefly running through what the membership is. So we have core membership of 24 experts on this panel. And as you can see, there are multiple professionals on this who have their multidisciplinary role, starting off from ourselves as pediatric oncologists. We have the radiologists, the surgeons, people who are immunotherapy experts, who have expertise in the new agents. And let's not forget our radiation oncologists. In addition to that, we heard Helen Pearson's name being mentioned. She too comes onto this panel as the nursing representative. However, we do not have a histopathologist, but we have not found that being a compromise on this. We have a tremendously helpful admin support at the moment to help us do this job. But what we've also helped in this process is we invite sometimes other pediatric oncologists from other centers, as well as we have trainees who have very much elaborated the educational aspects of this. So this is a virtual meeting of professionals, and this is hosted by our hospital, which is the University Hospital Southampton, in the auspices or umbrella of the Children's Cancer and Leukemia Group, or the CCLG. We meet twice a month, every second and the fourth Fridays. In fact, the next meeting is tomorrow, and we meet roughly for about an hour. We say 1 hour, but you can see most of the time we overrun because everybody wants to do their job and do it well for you. And we try to maximize it and discuss about 4 patients, sometimes 5 patients per meeting. But what I would like to highlight is we have an advisory role only. This is not an MDT. So what we feel that we should be achieving from this is offer you support, and also offer you support in your home environment, meaning with your clinician. So that, as we have said, it's a shared decision making finally as to what is best for your child in that particular situation. And ultimately, it is aiming to improve the outcomes. So what are our processes? So we have an infrastructure that is well established. As I said, it's a virtual meeting, and we do not invite the parents, and I'll mention the reasons later, but also how you can overcome that. So we have terms of reference that all of the clinicians are aware, and we regularly educate, apart from our neuroblastoma experts, all of the pediatric oncologists in the country. In fact, we've literally come out of a very successful education session over the last 2 days, highlighting how we work and how they can come to us. In addition to that, we have a very detailed referral form, which will give all the details of your child with regards to the presentation, regarding the scans, investigations, biology, which is right now very, very important, but also what treatment has taken place and how they've responded so far, so that the better the question that is asked, hopefully you'll get more clarity on the answers. And obviously, we do need to see the imaging, so the imaging also comes over, which is relevant. Ultimately, it is your clinician who comes over to the panel virtually and presents your child so that we have a detailed discussion and make sure that the outcomes from this are then disseminated, meaning we send the minutes back to your consultant. So please request them to show you the written minutes that are sent back to them. And we've also requested them to put it on your electronic document, so it is there for you to refer back to even later. So what is our remit? We hope we can continue to provide this advice, especially in these complex situations where your child needs multimodal treatment. Or it might be just you want to be reassured that your child is getting the best possible care and you've not missed out on anything, like a second opinion. But our other bigger remit is we want to support equitable and evidence-based access to specialist therapies all across the UK, and not just make it a postcode lottery depending on which part you're coming from. And obviously, we are heavily emphasizing on recruitment to whatever eligible or existing clinical trials, or giving you pointers as to what trials are upcoming. But we will be honest in saying these are the ones that are in the UK. And if we do know there's something abroad, we do mention that, but it will be ultimately a discussion you'll have with your local team as to how you can access that if that is valid. So in other words, we hope can enhance your experience in care, but at the same time contribute to education, not only yourselves and the professionals around, but even ourselves. As professionals, we continue to learn. But we have also contributed this way to audit as well as research in terms of many projects taking off from this that has, for example, been adult neuroblastoma, which now we have more and more adults bringing patients to us because adult neuroblastoma world doesn't exist. So ultimately, how does this panel help your child? So it is to provide the expert review of your own child's details and care in one place. So you're not going to different places to find out what is the best chemotherapy, what is the best surgery, do I need to go for radiotherapy, for example. Ultimately, it's the consensus recommendations from multidisciplinary experts that is going to be given as a complete total single opinion as to how to proceed forward. Additionally, awareness for yourself in terms of what's available in the UK, but also within the international arena of some advanced therapies. We are quite keen that we move forward. So we have a performance analysis as well as an annual general meeting on an annual basis, of course. And in fact, that is what we had yesterday, where we go back and reflect on the cases we've discussed, which centers have referred to us, some of the subgroups we have spoken about, and have we given the opinion and what have they done with that opinion. So in other words, feedback is something we have collected in the past, but we will continue to collect. So that is where I think, even though you feel you're not attending, you will be asked as to how the opinion was shared with you. Was it what you expected, did not expect, and how it changed the outcome of your child? And I'll just run through some of the specific examples where that was quite relevant. So this is just to give you a rough idea over the past years, how many referrals we've been having. And as you can see, constantly in the past 3 years, we have anywhere between 75 and 78 referrals. And many of these come through the panel, but sometimes because we have this meeting only twice a month, it is not adequate in a timely fashion for some of the parents. In such situations, we also do it by email, which we have counted in. You may think, well, my child has been discussed once. Maybe that is all, is it? Or can I go in again? What we are interestingly and increasingly seeing is that we are now having patients being discussed not once, twice, 3, or even 4 times. In other words, follow-up discussions are also taking place at different time points now, and definitely I would encourage you to ask your clinician about that. And roughly in the last year, you can see about 48% were almost follow-up, meaning they were being discussed for more than once, and the rest of the 52 were new patient discussions. And this is just to show you a map. We have 21 centers across the UK, the Children's Cancer and Leukemia Group, and all of them have referred patients to us. And roughly, just to give you some numbers, over the past 9 years, over 526 patients, or rather episodes, have been discussed. And many of them, especially now almost coming up to 50%, more than twice, and on an average of 4 a month. It does not matter which type of neuroblastoma your child has. Obviously, high risk would be the most important one that has the most challenging decision making. But roughly, you can see the high risk neuroblastoma, the refractory and relapses are. The relapses are roughly about 35% of our discussions as to what do we do next, second line, third line, fourth line treatments. And roughly a third of these patients are refractory patients, meaning they haven't responded to initial treatment. So how do we go forwards? But let's not forget, 50% of the patients with neuroblastoma diagnosis have the low intermediate subtype. And even those can be challenging. And we've had about nearly a third of those patients being discussed in this panel. So the questions are very, very critical in terms of what is your question. So the better the question, the better the answer. And so we have subdivided our questions into, is it a surgical question? Does it relate to radiotherapy? Does it relate to chemotherapy? Or is it a combination? And hence, we try to tease out what is it that is relevant for your child, but you speaking to your consultant or your consultant realizing these are the important things is what's discussed. And this is roughly the percentages of what we get. So I just like to run through 2 examples because we talk a lot about what about next chemotherapy, which trial. But there are 2 other resources that the panel offers, which is local therapy. What you will realize is it's also surgery and radiotherapy that contributes to the cure of your child in the context of high-risk neuroblastoma, and surgery definitely in the context of low and intermediate risk neuroblastoma. So what we have done is we have now designed a proforma, plus we're going to be asking your local team to give us the specificities of some of these questions so that we can come up with answers, because we have 5 surgeons as experts on this panel who are very, very experienced. Simple example being, is it regarding the feasibility of surgery? Say, for example, your local team says surgery is not possible right now because A, they haven't responded very well to the initial induction chemotherapy, or it is wrapping around big vessels, and so we are going to cause significant morbidity. Or they may say, well, actually, it's infiltrating. For example, it's very close to the kidneys and we are worried about it. So simple things where you need to understand, and is it the best opinion in terms of surgery for your child or not, is something we offer. And let's not forget, in the relapse situation, a surgeon is needed because we want more tissue. We want to understand more about the biology. And certainly there is the SMPs2, which is a new study, which is also characterizing these molecularly so that we can direct targeted therapy. Sometimes it is about the safety of the surgery, and in such situations, we open an open forum. Please come and discuss what your thoughts are, what your concerns are, and let's see how we can mitigate it and how we can discuss about it. Because sometimes it's not just one option, there may be 2, 3 different options. And surgical risk factors, like I described, close to vessels or important structures. We may come back and ask your local team to do more scans because we want to understand the tumor better to decide, is the surgery really possible, or actually is it an unresectable tumor? And sometimes, if it is because of issues with the kidney, how do we go about renal conservation, for example? And lastly, in some situations, surgery may actually not be possible. And in such situations, what are your alternatives? Like, for example, should we go for a very large biopsy? Should we go for embolization? Or is there a role for combining chemotherapy and some radiotherapy in such situations? In other words, please ask specific questions when you feel uncomfortable that is this the right decision. So in other words, we need the imaging. Plus, we have also encouraged your local surgeon to come along so that it can be a helpful discussion that once they come back to you, they can say, well, this is what 5 other experts in the panel said, and therefore, this is how we can look at it going forwards. Similarly, with radiotherapy as well, remember, we need to know whether your child is eligible for protons, eligible for a higher dose, and therefore having those discussions early is quite important. And this is another valuable, you can say, resource that we offer. And once again, we invite your local clinical oncologist if it is from your local center, but there are clinical oncologists already on the center who do the protons from UCLH here, and obviously your own surgeon. So, in other words, how does this panel really help you in this whole quagmire, if you want to call it, of decision making? It is to provide you some options when you're at crossroads, which is reliable, evidence-based, and perhaps coming, we hope, from the best of the experts in this country, but also who are some of the international experts. In this process, we want you to feel comfortable with your local team when they are explaining the choices and uncertainties, having talked to us on the panel. In that way, we hope we can strengthen the trust, especially when the views of your team own MDT is the same as what we do, or if it is different, try to understand with your team why the difference is so that you're all on the same page, but actually go ahead together. So if you would like to ask for a second opinion, I would say this is perhaps where I would be directing you to go about this process. So first of all, ask your own consultant, pediatric oncologist, can my child please be discussed on the NAP? It doesn't matter when. If you feel you want just that second opinion to reassure yourself, we are very welcome, or rather we welcome you for that. Or you might want to say, we are thinking about a second opinion. What do you think is the best way to go forward together? So you will already know, but I would like to highlight there are already second opinions existing within the NHS. Your own local MDT, that is multidisciplinary team meeting, will be discussing your child. But sometimes you do require that extra reassurance by making sure you have had another tertiary center look at this. And of course, we as a national panel is also a resource where we are bringing multiple center expertise into this. And what I would also suggest is please ask once you have known the child has been discussed in the panel about wanting it in writing. Yes, it's easily said, but you might still say, well, it really feels hard to go back to my consultant to actually ask this because somehow I don't feel comfortable. In which case, you might have a better, warmer relationship with your clinical nurse specialist, for example. And let's not forget charities, big charities, and definitely for me, on this forum, I would put out Solving Kids Cancer. They have done stupendous work in navigating you through these difficult situations and supported us as clinicians as well in that process so that together we can move forwards rather than you having to do alone. I'm quite conscious all of what we have said is within the UK, but what I would like to reassure all of our international families is the same process. Contact your own oncologist. And being a world where we all work together in collaborative groups such as the SIOPIN as well as the COG, we do have experts in every country who would actually want to be involved in such situations. So get your oncologist to approach them. Seek what the formal route of opinion, second opinions you can obtain from your own center, because every center will have that process. And if you don't know it, find out. And let's not forget charities, national, international, will also help you in that process. And the power of parent group has already been explained to you. But as we said, just be careful about the practicalities. Like, is it a pure advisory route you're going through, or has your child got to move for the local treatment? What are the costs? And if this is something your local center can't provide, go back and ask them, is this something you are willing to share with us? Because ultimately, it's the responsibility of the local team as well. So if you're trying to prepare for a second opinion, I would say these are perhaps my top tips. Write down your top 3 questions. Gather as much of information as possible regarding the staging, the diagnosis, the test results of your child, and then ask your local consultant who will discuss your patient and how and when will you hear about these outcomes, wherever the second opinion is. And when they do give you that information, please, whether it is virtual or in person in consultation, try to take somebody else with you as possible, because that helps with the note taking as well as remembering information, because 4 pairs of ears is always better than 2. And remember, you do not need to make any decisions immediately. Take it home, digest, think about it, speak with your families, and then you can make some decisions in a shared way with your local team. So I think I will end by saying what matters most to families is having that clear, honest explanation at various time points, such as diagnosis, the prognosis, as well as what are the options. Feeling listened to and respected and being asked what matters the most, I think is really crucial, and we are trying to help you there. Consistency and coordination when you have to navigate between so many teams is difficult, and we hope we can achieve that. And ultimately, it is giving you that confidence that you're not missing something that is available out there that you do not know about, is something we also aim towards. Last but not the least, this is emotionally draining. Practically, you need all of that support in a number of ways: psychological, having a social worker, charities, and peer parents. And we hope we can do that together and not yourself in isolation. So in summary, I would like to say second opinions are a normal part of what I would describe as good care in complex cancers, so that we can not just feel confident ourselves as professionals, but also y'all that it is the right decision. UK has this resource of the NNAP, where we are able to provide expert multidisciplinary input for your child and support you through your local team in order to do that. Anywhere you are, it is okay to ask for a second opinion and to take time to think. So do not hesitate to do that, because your questions are ultimately central to your child's care. And let's not forget, you are the advocate for your child, and you have that parental responsibility. And we definitely respect that, and we want to support you there. On that note, I would like to say thank you very much, and happy to take on more questions.
Oh, thank you, Dr. Ramya, for that brilliant presentation. That was absolutely excellent. And in fact, you cleverly anticipated a lot of the questions that came flying in. So you talked about what to do in other countries. Several were interested to know if they were from another country, they could be covered. They also worry about offending their clinician, their oncologist. And I think you very sensitively covered that. I love that you covered that sometimes a relationship with the CNS is a little easier. So thank you for that. There was a question, though, about how often do you see a difficulty in reaching a consensus when the panel meets?
So, how often we see a difficulty? We do encounter difficulties, not so often, but I would say we do see it. And in such situations, what we do is we put out what we call options, because sometimes there's no right option, but there is no wrong option, but there are many right options. And that's where we would then go through the pros and cons of those various options and hence lay it back to the local consultant, because we do not know the family. What is the background in terms of what is the toxicity of treatment? Simple example. What is it that the parents actually want? What matters to them the most? So bringing that nuances into that final opinion is what we leave with the local clinician, but that's how we navigate it, I must say. And in rare instances where we feel that there is really nothing within the UK, but we strongly feel that there is a trial, say, for example, Spain or New York, wherever, we would say, well, these are the trials, these are our collaborators, help us to help you.
That is a brilliant answer. Excellent. There was also a question about post-treatment, the stress that families go through. They've finished treatment, now they're all done. But there's nothing like the National Neuroblastoma Panel for late effects or concerns of that sort. Is that right?
No, but I can add, because the other hat I wear is I chair the Quality of Life Committee in the SIOPEN, which is a new committee. I wouldn't say new, is a committee that is beginning to understand all of this. And what we hope in the longer term is to incorporate this not only into our treatment regimens, which is what I'm trying to do nowadays in the NAV when we are discussing treatment options. Yes, we need cure, but we also need to be talking about the quality of cure and how is my child going to be living in, say, 20 years' time. So we do bring those thought processes when we're talking about radiotherapy, simple example. How are we going to spare the kidneys? Simple example.
Exactly. Yes, I'm very glad to hear that. It's good that you have the connection between both of those very important efforts. Well, Mandy, if you could turn on your camera, we'd like to welcome you back. I have one question for you. Sorry, I should have invited you back sooner. There was a question about what decision you made for Peter's clinical trial. So could you tell us a little bit more about that clinical trial?
Yeah, so we had a situation, like I said, where we had the bone marrow was clear, pelvis was clear, but he still had his tumor lighting up in MIBG, but it seemed to have been stable for quite a long time. And so there were no options in the UK that he was eligible for. He just wasn't eligible for any trials. He was, ironically, he did not have enough disease. It was one of those sort of strange situations that you find yourself in where you don't want your child to have more disease, but you do want your child to have an option to be treated for the disease they've got. So, and at that stage, we didn't have a PET scan. We didn't know that this was, well, we don't know when it became non-active disease. That's the whole point. We didn't know. So we sought second opinions with Spain to look at the naxitamab trial, and we sought second opinions with America for the DFMO trial. And we were weighing up these two different options because the naxitamab meant more immunotherapy, and he had reacted well to immunotherapy. The DFMO potentially had some good effects in terms of making sure that all disease was sort of matured, or I don't know quite how to say it. As I said before, I'm not great on the science of everything. And it was just trying to work out which was going to be the best option for us. And in the end, it came down to our personal circumstances. That our personal circumstances were that we could manage the occasional trip to America for DFMO with a treatment that was daily pills, that minimized side effects, that minimized impact on Peter's daily life and allowed him to go back to school more full time, all of that kind of thing, versus a treatment that would have involved moving to Spain pretty much for the duration treatment with some pretty harsh side effects. There wasn't data to help us make a decision. So we just went with our gut in the end, having discussed it in many, many different ways. And the trial that he was on was I can't remember the name, I can't remember the number of it, but it was an expanded use trial.
Mm-hmm.
So he was allowed to be on it with visible disease. And that's how he ended up on that one. And yeah.
Thank you, Mandy, very much for describing your journey with Peter. And I'm so sorry we're out of time for more questions, but I want to thank you, Mandy and Dr. Ramya, for presenting today. We really appreciate that. We want to thank our sponsors, United Therapeutics, Norgine, and Recordati Rare Diseases, for supporting this webinar. We would like to remind you that this session has been recorded, so you'll be able to play it back at any time. We hope you'll also join us next Thursday for the second webinar in our 6-part series, Understanding Current Frontline Treatment, COG and SIPEN, with speakers Dr. Claudia Pasqualini, Dr. Sarah Federico, and Nick Bird, Solving Kids Cancer trustee and parent advocate. Thank you so much for being part of this with us today. Thank you and goodbye.
Thank you very much. It's been a pleasure.
Yes.